Assalamu alaikum. Dear mentors, colleagues, seniors, guests, thank you very much for being with us this day, fifth version of MOCAT. So I'll present to you the corneal refractive surgery. Regarding the history, is the sound okay? Okay, good. So regarding the history, at the beginning, there are thoughts about refractive surgery, how to reshape the cornea by doing incision. And this is done before this age. But during the 8 years ago, it really started with Father Waklo. He is a Polish missionary, an ophthalmologist who works in China and then in USA. He's starting doing an incisions. But the real impact on refractive surgery done by Professor Julio Ignacio Barraquer, who present the term keratomelusis, introduced this term. And this term means that we are reshaping or carving the cornea. So in this case, the patient was under general anesthesia or local anesthesia. Will take a tissue removal by a special microkeratome done by him called a Barraquer microkeratome. And this disc of the central of the cornea out of the patient, freezed, carved, the way they call it, cryolathe, and then to reshape the cornea, and then repositioned to the patient by sutures. Imagine what an ugly surgery. But this is really, he was regarded as a father of refractive surgery. And during this time, it is the first time that human surgery, that part of an organ was separated from the organism to modify its function, in our case, the refraction, and replaced in its original position by suturing. And it's the first time, that we are using a computer-generated, first time that we use the computer to guess or to count how much we will take. So it's the first time to start this, and the first time that a part of the tissue is organ separated. And after Professor Barraquer, there was an area during 70 of radial keratotomy by Professor Vidrov from Russia. But an era of excimer laser technology developed during 80, and Professor Margaret McDonald from USA did the first PRK during 1988. After that, it's a painful surgery and so on. So I am delighted to have a good relation with our mentor, Professor Palikaris, who did the first LASIK surgery in the world. And then LASIK go more for more precision, topo-guided, detailed mapping. During the area of 2010, SMILE began, an era of lenticule extraction with a Visiomax from Zeiss. And after that, during 2020, other companies started working on this and invested in lenticule surgery, Clear from LDV, Smart from Schwind during 2020, then SMILE Pro, which is a new version from SMILE during 21, they get CE mark, and Silk from Johnson & Johnson during 2023, they get the CE mark. But how this femtosecond laser acts? When a high-intensity pulse of near-infrared laser hit or focused on a cornea, this will cause a plasma. And this plasma contains a cloud of free electrons and ions. And this will heat the tissue nearby, creating a shock wave, and this shock wave will end with a cavitation. So this is the primary effect of the laser, depend on the focus and the spot. And the secondary effect is development of a cavitation. A cavitation which contains water vapor, CO2, and nitrogen gas. When these bubbles coalesce each other, they separate or cleave the tissue. So there are direct effects of the laser and indirect effects. And there are some differences between the technology using this. The technology that use the direct effect more, they use a small spot of laser, contagious, each spot near the other. There is no space between them, and very small, and they have a low energy. While the other, who depend on the bubbles, they should have a high energy, and they should leave, they are large spots, and leave a space between them, free area, because they depend mainly on the bubbling, not on the plasma. So, a high with low energy system, a high pulse energy, they should have, or they're better to have a low repetition rate system. They don't need a very high repetition rate because they have a large spots, distance between, they have a distance between the spots depending on the bubbles. So they are produce a larger, more disruptive cavitation bubbles that primarily separate tissue by mechanical force. While a low energy system, they should have a high repetition rate. Why? Because they have a small spots near each other with a very small bubble, though they depend mainly on the plasma. But they have a very smooth cut. Why? Because a small bubble lead to lead cut, while the other have a large spot, depending on the bubble, so the cut will be slightly undulant, not so smooth. And these are the 5 platforms available nowadays in the market. I really started with Zeiss. This is regarded as the mother of all lenticule surgery. I did around 6,000 cases with this. And then we have a Smile Pro, and I did around 4,000, more than 4,000 cases. But nowadays, I started using a low energy technology. And as I said, they have a very small spot, contagious, each one near the other, and with a very high repetition rate, 10 megahertz, with a pulse duration. To have a very small size spot, you should have a pulse duration short. This is the shortest pulse duration. The other have a larger pulse duration. And I really worked on a 41 nanojoule. This is the lowest energy available in the markets. Really, it is working between 40 and 90. I work on 41 with a very good separation. This technology, the only one have a biconvex lenticule, and flattening of the cornea allowed post-docking centration. This is other important things. While the other have a high energy, so the spots are large and depend on the bubbles. I did around 4 cases, 4 patients, the eye with Elita, Johnson & Johnson, and the other eye with Smile Pro. Four of them, all of them say that the vision next day, next morning, is much clearer in the Silk than in the Smile Pro. And this is the patient, the OCT of the patient. See the first post-operative day with Silk. See how clear, how smooth the cut, the interface. This is the interface. The lenticle is extracted. While the other one with the Smile, see the haze around. There are much of inflammation and haze around the interface. But how cornea responds to an insult? Let's put it in this way. So once there is an insult on the cornea, there is an insult here. Insult like incision, trauma, laser in form of either femtosecond, as in our cases, or excimer, or even manipulation, like when you take the lenticle out, when you go inside, all these induce inflammation, and there is a reaction of the cornea. So, once there is an insult, the corneal responds in this way. There is a much production of cytokines and growth factor in the form of interleukin-1 and TNF, tumor necrosis factor alpha. This will induce and make the keratocyte, the nearest keratocyte, to die. The first reaction. This is apoptosis. This gives a signal to the deeper keratocyte to have a proliferation and migration, and forming a fibroblast. This is a special forces. The usual keratocyte is inert, inactive, while a fibroblast is an active cell. So this will respond going to the area of insult, whether it's a femtosecond, a excimer laser, or an injury, even the incision, you go through it. This is trauma to the cornea. This will close and have an anti-inflammatory effect. But sometimes the insult is so severe that affecting even the basement membrane of the epithelium, this will produce more proliferating or migrating growth factor beta, and this will change this fibroblast to myofibroblast. This is a special force. This is like SWAT. They are very severe defensive cells. It goes rapidly to an area of injury, and if the insult is severe and the Bowman cell, the basement membrane is still not closed, and the inflammation is still severe, this will go into causing irregular cornea and might lead to haze or scar of the cornea. But if the insult is less, this cell will go into apoptosis. And there is inflammatory cells which phagocytize the cells, and the cornea still clear. So this is how the cornea reacts to any insult, whether in a form of a laser or a trauma or something like that. So responding to the inflammation, there will be either overcorrection, undercorrection, regression, irregular astigmatism, or even the Alcair haze, depending on this response of the cornea to the insult. This is the state of the same thing, and I think I have to say thank you. Please allow me to introduce my mentor, Professor Palikaris.
I'm very impressed. I need you.